We're going to give folks another minute or so before we get started. So bear with us another minute before we dive right into today's webinar. All right, good morning and welcome everyone. Thank you so much for joining us today for our webinar. My name is Meg Beyer and I am the Director of Healthcare Innovations at the McSilver Institute, one of the TTAC partners, and I'm so happy to be joined by our presenters and you all today for our TTAC webinar on what are perinatal mood and anxiety disorders. A few logistics about today's webinar before our presenters begin. As we've done in the past, this webinar is being recorded and will be posted along with the slides to the TTAC website. So if you want to refer back to some of the wonderful content and information you learned today, you'll be able to do so. We are going to take questions for our presenters throughout the webinar, and we ask that you chat in your questions using the chat box functionality, which can be found on, it should be on the right-hand side of your Zoom. It's on the right-hand side of my Zoom screen this morning. We ask that you, on the drop-down, you'll see a little, it says 2 in colon. What we ask is that you chat in your questions to everyone. That way our panelists, our presenters, and our participants, our fellow participants, can see what your questions are. As I said, we're going to be taking questions throughout the entirety of the webinar, but we're saving time at the end to address your questions. So don't hesitate to chat your questions in. We're taking care of collecting them and putting them all in one central place, and we'll review those questions at the end of the webinar today. For those of you who may be LMSWs or LMHCs and are interested in obtaining continuing education credits, you will be eligible to receive 1.5 CE credits for attending this webinar. What we're asking is that sometimes you can join Zoom just by your phone. However, in order to obtain CEs, we do need you to log in via your computer link. So if you're joined by only your phone today, that's great, but if you'd like to obtain CEs, we do need you to join through the link that was provided when you registered so that our system can recognize your attendance and you can receive full credit for your attendance today. Further information and instructions on how to obtain those CEs will be distributed following today's webinar. Finally, at the end of the webinar today, we are going to be sending around a link via the chat box for our feedback survey. We ask that you click the link that is shared in the chat box and complete the feedback survey. I know folks get asked to complete a lot of surveys and provide a lot of feedback, but we do review all the feedback surveys that are submitted, and we appreciate it as we take what you share with us in terms of your feedback and help us to understand your experience and improve upon our future offerings for TTAC. So thank you in advance for filling out those feedback surveys. And with no further ado, I want to thank you all for joining us, and we'll hand it over to our partner, Evelyn Blank, the Executive Director at the New York Center for Child Development and the Director of TTAC, who will walk us through a brief introduction before our wonderful presenters will get started today. Evelyn?
Perfect. Thank you so much, Megan. If we could just go to the next slide, just a brief statement about who we are. The New York City Early Childhood Mental Health Training and Technical Assistance Center is funded by the New York City Department of Health and Mental Hygiene. And TTAC is a partnership between the New York Center for Child Development and the McSilver Institute on Poverty, Policy, and Research. New York Center for Child Development has been a major provider of early childhood mental health services in New York, with expertise in informing policy and supporting the field of early childhood mental health through training and direct practice. Our partner is the NYU McSilver Institute for Poverty, Policy, and Research, which houses the Community and the Managed Care Technical Assistance Centers, otherwise known as MTAC and CTAC, which offer clinic, business, and system transformation support statewide to all behavioral health providers. TTAC is tasked with building the capacity and competencies of mental health and early childhood professionals through ongoing training and technical assistance. If we go to the next slide, there's just a screenshot there of our website, and I wanted to direct people to go there to see our archive trainings, and that each of our presentations, we have both the presentation slides as well as the recordings of the presentations. So I would encourage people to go there. We've got a whole host of trainings, everything from very foundational topics to some real cutting edge topics with some national experts. So with no further ado, I'd like to introduce our two guest speakers today. We're very excited about this important topic. Dr. Catherine Birndorf is the reproductive psychiatrist who is the co-founder, CEO, and medical director of the Motherhood Center of New York. Dr. Birndorf is founding director of the Payne Whitney Women's Program at Weill Cornell Medicine, New York Presbyterian Hospital, where she is clinical associate professor of psychiatry and obstetrics and gynecology. A past board member of Postpartum Support International, Dr. Birndorf now serves on the President's Advisory Council. For 10 years, Dr. Birndorf was a regular mental health columnist for Self magazine and has appeared on numerous television programs, including The Today Show, Good Morning America, MSNBC, and CNN. Dr. Birndorf's first book, The 9 Rooms of Happiness, was a New York Times bestseller, and her most recent book is entitled What No One Tells You, A Guide to Your Emotions from Pregnancy to Motherhood. Paige Bellenbaum is the founding director and chief external relations officer at the Motherhood Center of New York. For the past 20 years, she has worked in the fields of public policy, advocacy, and clinical care. After her first child was born, Paige suffered from severe postpartum depression and anxiety that nearly ended her life. Once she began to heal, she became committed to fighting for education, screening, and treatment for postpartum depression so that no more women would have to suffer silently. She drafted legislation in New York State that was championed by State Senator Liz Krueger, mandating hospitals to provide education on perinatal mood and anxiety disorders and strongly encouraging screening of all new and expecting mothers that was signed into law in 2014. Since then, Paige has been an outspoken advocate on the issue of postpartum depression and uses her own story as a tool for change. She has appeared on The Today Show, Good Morning America, NPR, PBS NewsHour, and in Women's Health, Fortune, and the Wall Street Journal. So it's now my privilege to turn it over to our presenters.
Thank you so much for that wonderful introduction. And it's just such an honor to be here. I'm seeing that there's so many people that are present today, and it just makes Dr. Birndorf and I very, very happy to know that there is a changing face to maternal mental health. More and more people are starting to pay attention to this critical issue now more than ever. Dr. Birndorf and I have been speaking to quite a few press outlets lately and screaming from the top of our lungs, we are experiencing a maternal mental health crisis, and the pandemic has everything to do with it. So it's very timely that we are here with you today speaking about perinatal mood and anxiety disorders, and I'm very hopeful that you'll glean a lot more about what they are, what are the signs and symptoms, what are some ways that we can better screen and educate women and their partners to be more aware of Pmads, which is the acronym we'll use to describe them, and most importantly, how we can connect women to the treatment and support that they so desperately need to feel better. And so I'm going to hand off the first few slides to my dear colleague, Dr. Birndorf.
Hello, everybody, and thank you for that those lovely introductions, Evelyn and Megan. Really glad to be here and to talk about Pmads. We're not thrilled about this acronym, but it works, and what it stands for, perinatal mood and anxiety disorders, and it covers everything, which is why we use it, because most people think about postpartum depression, but we want to open that up to during pregnancy, after pregnancy, and include all different kinds of mood and anxiety disorders. So Pmads, or perinatal mood and anxiety disorders, are a group of illnesses that affect at least 1 in 5 women during pregnancy and the postpartum period. They cause emotional and physical problems that make it hard for women to function adequately. And we need women function adequately, not for themselves, but for their families as well. So what Pmads include, and we're going to touch on today briefly, but these are all lectures in and of themselves. Perinatal depression, which is, these are sort of the top things that you can kind of think about that help categorize these illnesses. low mood, sadness, diminished pleasure, hopelessness, perinatal anxiety, constant worry, intrusive thoughts. You can't turn your brain off. You also have physical symptoms as well, shortness of breath, feeling panicky. Perinatal OCD, obsessive compulsive disorder, thoughts that go round and round in your head, rituals, compulsions like washing, counting, cleaning, hoarding. And all of these things are meant to neutralize anxiety. Perinatal PTSD, where someone has either witnessed or been part of a near-death experience where they feel that they must avoid the scene of the crime, so to speak. Nightmares, they have flashbacks, and they are hyper aroused in terms of just being on edge. Fight or flight system is aroused frequently. And then there's postpartum psychosis, which is our most concerning, it's the most concerning PMAD because it is most life or death. And it can include delusions, hallucinations, paranoia, and disorganization. And we'll talk more about all those things. That's the brief overview.
So why are, oh, sorry.
Go Paige, go.
So why are PMADs important, which is really why we're all here. So as Dr. Birndorf mentioned in the very beginning, in general, 1 in 5 women experience a PMAD in the perinatal period. Now, this is a very very kind of modest estimate. For those of us who do this work, we know that PMAD rates in general are more like 1 in 3 women, but because of the stigma and shame that surrounds maternal mental health, so many women stay silent, struggle silently, don't get the treatment they deserve, don't tell anybody how terrible they're feeling. And since the pandemic, PMAD rates have risen exponentially. And we have a slide in just a moment that's going to show you how much, but some research suggests, particularly out of Canada, that those rates have gone up as high as 72%. And that has everything to do with the isolation, the lack of social support, the managing even higher levels of stress and anxiety, particularly pertaining to health and wellness, considering the pandemic itself. So we have never seen anything quite like this. Up to 80% of all cases go undiagnosed because of the shame and the stigma. They go undiagnosed and untreated. There's also, on top of the shame and stigma, a lack of awareness. This is starting to shift. Thankfully, we are paying more and more attention to maternal mental health, but we have a long ways to go. And there's also a scarcity of specialized treatment options. What we do at the Motherhood Center, and we'll talk a little bit about this at the end, is we specialize in treating PMADs. But there isn't, it's a growing field, but it's still a very small field of clinicians, both therapists and MDs alike, who specialize in maternal mental health. What we do know is that low-income women experience PMAD rates at much higher levels, up to 40%, and this is pre-pandemic. So since the pandemic began, we're seeing rates as high as 50% in that regard. A lot of us, when we think about PMADs, we think about postpartum depression or the postpartum. That's kind of the key word. And what most people don't know is that 50% of PMADs actually originate during pregnancy. So half of all cases, women and birthing parents become symptomatic during their pregnancy and start to develop these symptoms. PMADs are the #1 complication associated with childbirth. And I really want that to sink in because it is such a critical and important point. We have a slide in a little bit that talks about the percentages of women that experience hypertension and other types of pregnancy-related issues from a physical perspective. And yet, PMADs are the #1 complication associated with birth. When we don't treat PMADs, this can lead to poor mother-baby attachment and developmental delays in children that can have longitudinal impacts and effects. And PMADs are the leading cause of maternal mortality, both here in New York City and the US. And thankfully, we are paying much more attention to the unnecessary maternal mortality rates that exist in this country. And what we learn, and every city and state has a special coalition or collective of people that are looking at this research, but we are finding that the leading contributing factor for those maternal mortality rates has to do with suicidality and substance abuse. And so we are finally now starting to pay attention to those numbers as well. As mentioned before, the pandemic has had a total impact on new and expecting mothers. It's left so many more mothers feeling those symptoms of depression, in particular anxiety. There's been so many studies that have been conducted across the world that have found an increase in rates from anywhere to 40% all the way up to 72%. But across the board, our colleagues are feeling it. Across the US, we have certainly seen an incredible uptick in people that are looking for support and services. And so now really is a good time for people to be interested in learning more about this because there are so many women out there that are struggling and really would benefit from the support and clinical treatment to get better. I'm not sure why the text is showing up green, but I'll take it. So there's a lot of stigma and societal expectations that go along with why women keep silent, right? That 80% of all cases go untreated and undiagnosed. Well, in this country, as we all know, there is some taboo that still exists around mental health, in particular, maternal mental health, right? When we think about turning into a mother, becoming a mother, and motherhood in general, we have a very kind of romanticized and glamorized version of what motherhood is. It's this blissful, wonderful, magical experience where, you know, especially when the second trimester rolls around, we start glowing, we feel connected to this baby, we feel so excited. The baby comes, they put the baby on our chest, we feel this immediate bond and this unconditional love. We see it all around us in social media. We see it on commercials and TV shows. It's this very only beautiful experience, right? And for many, many women and birthing parents, it is that. And for many, many others, it's a little bit of that, but a lot of other stuff. And then for even others, it's none of that, right? There's a spectrum of how people respond to the perinatal period. But because that is what we see, when we don't have that experience, we feel like we're doing something wrong, we're a terrible mother, that we're not cut out for this because we're supposed to feel this other way. And so we don't tell anybody, right? Because it's not the way we thought it was supposed to go. And we live in fear. We think if I tell even my partner, let alone my friends and family, my doctor, my parents, anybody who knows me, they might think I'm just an awful person. I don't want anyone to know. And my biggest fear is that if I tell anybody how bad I feel, they're going to take my baby away. And sadly, we have seen this happen again and again across the country where women come forward and say, I'm not connected to my baby. I feel like I made a mistake. I'm having scary, intrusive thoughts of harm coming to the baby. And for the medical community out there that is not well informed on Pmads and the fact that they are a treatable illness and that, you know, in these instances, women would never cause harm to their baby 99% of the time. Without that insight and knowledge, sometimes those calls to Child Protective Services or even the police are made, and this can be traumatizing for a new mother, right? And it can separate families and have a long-lasting impact. And those are the kinds of stories that we see about and hear about most of the time. And so that has an impact on women and birthing parents. And so they don't say what's really happening. They wonder what's wrong with me. They think they're the only person who's feeling this way because we're not talking about the truthful parts of motherhood. And sadly, and this is shifting, a lot of people in the medical community don't ask, right? We have a saying at the Motherhood Center, the pregnant princess and the postpartum pauper. There is so much attention that is placed on a pregnant woman or birthing parent, right? And rightly so. But, you know, friends and family asking, how are you doing? How are you feeling? When is your due date? This, that, and the other thing. But then once the baby comes, we forget about mom. And so, especially pertaining to the medical community, figuring out ways that we can really strongly encourage screening to be an across-the-board practice would mandate, strongly encourage providers to implement screening practices into their ongoing treatment when they're working with perinatal women, and also be able to refer them to treatment and services. But we're just not asking enough. And there's an enormous amount of guilt and shame and isolation and worry that is associated for women that are experiencing Pmads. Dr. Birndorf.
So some of the risk factors that may lead someone to have a Pmad include, most importantly, a history of any mental illness. So if someone's coming into the pregnancy or has had a history in the past, either themselves or their family, they are more likely than someone who hasn't to have any one of these disorders that occur in the perinatal period. If you've had a previous Pmad, right? So let's say the first pregnancy or postpartum ended up with depression or anxiety, and you never got treatment. I mean, that may still be going on into the second pregnancy, but it also may have resolved on its own after a lot of time and a lot of suffering. But the chance of it happening again is great. And it keeps going up with each successive pregnancy or experience, a stressful experience. So stressful life events and circumstances, if people are struggling, and most people are, finances, relationships, physical or sexual abuse, substance use, recent losses, unresolved conflicts, maybe the pregnancy wasn't planned or it was conceived in an unfortunate nature. I mean, all these things contribute to potential Pmads. Unplanned or unwanted pregnancies, traumatic births, NICU experiences. These tend to be things about which people have acute stress reactions and can develop post-traumatic stress reactions, particularly if they have a history of trauma in the past. It gets recapitulated. And this pandemic, as Paige said, I mean, it's the isolation, the lack of social support, and managing higher than ever levels of stress and anxiety. Everything like this is all contributing to the increased levels of Pmads that we are seeing and hoping to treat. So the impact of untreated Pmads on families, we know that when there's an impaired mother-infant interaction or birthing person-infant interactions, there's potential trouble and there's more likely a Pmad that can develop, right? You can have moms who present with negative disengaged parenting behaviors. They ascribe feelings to babies. We have women who will say the baby doesn't like me. The baby's grimacing at me and really thinks that I'm a bad mom. And attachment, which is what's developing, and you bring with you your own attachment, which can be complicated. And when that's developing, it can also lead to insecure, anxious attachments with the current baby if we're not treating what's happening at present. We know children of untreated and depressed moms experience more behavioral, cognitive, and emotional problems, and they are susceptible to more psychiatric disorders. So it's really important. We sort of say at the end that if we're not treating the mom, we're not helping the child. A well mom is the best thing for a well child. So we have to sort of treat at many different levels, but we really need to make sure that the mom is okay.
We also always like to include, because there's always a multitude of participants in the audience, is that along with having long-lasting impacts on both mother and baby and child into adolescent and adult, there's also an enormous impact of untreated Pmads on society and on the workforce. There was a report that was released back in 2019 that found that Pmads untreated cost us about $14.2 billion a year, and that includes medical costs. This calculates out to about $32,000 for every mother-child pair affected. We've done our own research on this, and actually that amount is much more inflated per dyad. This is, again, kind of a humble number. And of the total cost, about 60% of that cost is related to maternal outcomes and the 40% related to child outcomes. So on top of those medical costs that are incurred, we also see In regards to the workforce, there's productivity loss because of the decreased likelihood of work. Presenteeism, mothers might be less productive or more likely to make mistakes at work, absenteeism, missing work, and unemployment, which also comes at an enormous price tag. And then if you see some of these other costs that are broken down in the last bullet, some of these other medical components include higher rates of preterm birth and maternal health expenditures. And then, as I'd mentioned a little bit earlier, when we talk about this concept of PMADs are the #1 complication associated with childbirth, we look at these other things that every new and expecting mother and birthing parent hears about: gestational diabetes, hypertension. These are things that the majority of us get tested for. But when we see the rates of women that are impacted, 2 to 10% for gestational diabetes, 5 to 8% for hypertension, and then we look at the modest number of 20% of perinatal women experiencing Pmads, we realize there's something wrong here. We need to be educating, we need to be screening, considering the amount of women that are experiencing Pmads in this country. And I always like to cite this one study, which I think it really speaks to how so many women and why so many women fall through the cracks. It's a study that came out of New Zealand with about 400 pregnant women. Of those 400, 92.5 completed the EPDS. This is the Edinburgh Postnatal Depression Scale. This is the gold standard in screening, which we'll talk a little bit more about when we get to our screening slide. Of the 49 women who screened positive, only 30.6% of those agreed to a mental health assessment. Of those, less than half followed through with the assessment, and only 2 accepted treatment. And so we see that cascade of how, even when we're able to identify it, there's so much fall off into getting women actually connected to the care and support that they need to feel better. So I had to slip this slide in only because it's my background and it's my passion, but just to also look at this from kind of a policy and legislative perspective. There's thankfully been a lot more progress in the right direction when we think about and talk about and look at movement in regards to Pmad education, awareness, screening, and treatment. One of the greatest things that ever happened that's not on here was the creation of Postpartum Support International, which doesn't appear on this timeline, which, correct me if this is wrong, Catherine, but I believe they started in the 80s?
Yep, mid-80s.
Okay, so they were like leaps and bounds above and beyond everyone. PSI has come to become really kind of the international go-to for all kinds of resources pertaining to Pmads, whether it's getting connected to treatment providers, education, all kinds of movements that you can partake in. But what we start to see is right around 2010, we begin this movement of other entities like the American Academy of Pediatrics, and then ACOG going on to look at Pmads and starting to encourage screening and education in regards to Pmads of both pregnant and postpartum women, and also from a pediatric perspective, certainly from postpartum women. In 2016, we saw the U.S. Preventive Task Force recommending screening. We had some federal legislation that was introduced in 2018, bringing postpartum depression out of the Shadows Act, which I'm happy to announce went from a total funding of $3 million to $10 million this year was enacted in the budget. So on a federal level, we're seeing a greater commitment to Pmad education, screening, and treatment. Not too long ago in 2019, right before the world shut down, the FDA approved a new drug called brexanolone, which is an intravenous intervention which women can take in the hospital, in a hospital setting that lasts for 3 days. And we're just now starting to see some of the impacts of that intervention in regards to postpartum depression. And then most recently in 2021, we saw the American Rescue Plan Act, which ensures Medicaid CHIP coverage to 1 year postpartum, which is very, very instrumental and important, particularly for low-income women. And then also in 2021, the White House issued its first ever proclamation on Black maternal health. So we have seen some movement. Again, there's a long way to go. There's many states that have their own legislation on the books that requires screening or strongly encourages it. What we really need is to focus on treatment, because as I've mentioned before, there's still a dearth of providers out there who specialize in this area of care. So we're going to shift over to a deeper dive into Pmad diagnoses and symptoms. And Dr. Birndorf is going to walk us through these next few slides.
Okay, so please ask questions in the chat if you have them. I saw one before that asked, you're not guaranteed if you have a family history or a history yourself of any kind of mental illness, that does not guarantee that you will have a Pmad. It's just more likely, particularly if, if there are stressful life events happening at that time, including a pregnancy. So perinatal depression. So one thing I want to say about all these disorders that I'm going to try and talk deeply about, but quickly, is that they are also disorders that happen at other times in life. They're not so special. So I just want to assure you that if you're familiar with these diagnoses, depression, anxiety, OCD, PTSD, psychosis, they're not so different, okay? It's the timing when they're happening. And there are some qualitative differences, and I'm going to point those out, but this is not super secret special, which a lot of my colleagues in medicine feel. They're like, oh no, we can't touch pregnant or postpartum women. That's not my field. I don't get it. Wrong. You can get it. It's not rocket science, okay? It is different in certain ways, but generally speaking, right now, we use it descriptively. Depression is depression. It is happening in pregnancy or in the postpartum, and that is why we call it perinatal depression, identified by timing. I do think there is more to it, right? We don't have the hormonal backup to support its uniqueness, and we don't have all sorts of differences to really say it is its own bird. But for the moment, we use timing as the descriptor to say when this is happening. So I see a lot of questions and I would love to answer them, but I'm going to not get distracted. I'm going to go forward for a minute and we'll do that at the end. So depression, we all know what that is, right? Low mood, sadness, tearfulness, loss of interest, joy, or pleasure in things you used to enjoy. Interestingly, asterisks here, in perinatal depression, rarely do you hear someone say they've lost joy in the baby or the pregnancy. That don't get thrown off. You can maintain joy in certain areas and not others, and that may be a symptom. Agitation or anxiety, a huge, again, many women won't say I'm depressed. They'll say I'm just anxious. That may be a sign of depression, or it may be anxiety, or they may be coexisting as they often do. Lack of energy, feeling slowed down physically, difficulty concentrating, hard to make decisions. People are quite indecisive or can be. Appetite and sleep disturbances, too much, too little of either, that counts. Feelings of guilt, shame, hopelessness, and possible thoughts of harm to the baby or yourself, or oneself. So you don't need all of these. You need some of these, and plus a few others, lasting more days than not over a 2-week period to actually have a diagnosis of depression per se. So we can talk more about that as we go forward. Perinatal anxiety, again, anxiety at large has to do with the idea of apprehension, dread, worry, and there are physical symptoms that are associated with it. Okay, so generally speaking, constant worry, feeling that something bad is going to happen, feeling like you can't turn your brain off, you're on a hamster wheel, right? People will describe, I can't sleep at night because the minute I stop doing or acting, I'm like, it's as if my mind just comes alive and keeps me awake. So people are not sleeping, they're not eating well, or they're eating too much. People can respond either way. And then the physical symptoms that often go along with anxiety are things like dizziness, heart palpitations. I think I'm having a heart attack. I think I'm going to die. These are things, nausea, feeling like you're going to throw up, having a panic attack. These can all be signs and symptoms of anxiety. Now, OCD, obsessive compulsive disorder, in the previous Diagnostic and Statistics Manual, the DSM, which we all, I'm sure, know about, which is just a list of symptoms, trying to cluster things, giving us a common language. It is not a Bible. It is a way for insurance to recognize that we can get patients reimbursed for services. But OCD got taken out of anxiety disorders and moved into its own category. So we separated out. It is a cluster of symptoms and signs having to do with obsessions, which are the thoughts that go round and round in your head. The O is obsessions, those are the thoughts. The C is compulsions, which are the actions. So just, and either way, you can have O, you can have C, you can have both. It's all meant to neutralize the fear of something bad happening. Okay, that's the easiest way. That's how I think of OCD. But these thoughts are intrusive often, they're persistent, they're repetitive, they can be mental images regarding the baby. You'll often hear this, very focused on the baby in the perinatal period, and they are upsetting. It is a key point here that they're upsetting. When they're not upsetting, and we're going to get to this later, you might be talking about someone who is losing touch with reality. There may be more along the line of psychosis or lack of insight. But when moms are upset by all these horrible thoughts in their head, I say to them, this is horrible. You are suffering. We are going to get you treated, and you are safe. Generally speaking, you are safe. When you are upset by I know it sounds, kind of, paradoxical, but that's what we see. So compulsions, things you're going to do over and over again, washing, counting, cleaning, checking, reordering things. There's a sense of horror about these obsessions and compulsions. We have moms who fear being left alone with the infant. They're going to hurt the infant. They are hyper vigilant in protecting the infant, but they don't want to go near a window. They don't go near a stove. They want all the knives removed from a kitchen. They don't want to be near things that they think somehow they will act. These are things you hear in perinatal OCD that make it really scary. Again, super treatable, as all of these are. Okay. Next is perinatal PTSD, so post-traumatic stress disorder. This is the idea that you can have intrusive re-experiencing of past traumatic events. Sometimes the past traumatic event is childbirth, is the labor and delivery. It was your treatment at the hospital, not being heard, not getting the help you needed, feeling left on your own. We see this all the time. I mean, how could birth not be a traumatic experience? Trauma, little t, but for everyone, not for everybody, but particularly those who have a past experience with trauma of any sort, the birth can recapitulate that experience and really make it that much harder. That in fact affects bonding and everything else. But flashbacks, I'm going to get back to PTSD, flashbacks, nightmares, avoidance of stimuli associated with the event. I mean, what if the event is the baby being there, right? Some people avoid their own babies. Include thoughts, feelings, people, places, details of the event, things that people will avoid at all costs. They don't go back for care because they can't go back to that doctor or that hospital where bad things happen to them. There's this persistent increased arousal, irritability, difficulty sleeping, hypervigilance. Your fight or flight system is activated. People startle very easily. Anxiety and panic attacks can be part of the picture, and feeling a sense of unreality or detachment can be part of this. So we see a lot of this, and it is really important, again, for every one of these perinatal disorders to get treatment. And then this is a medical emergency, okay? This is our biggest, this is what we see, what we worry about the most. It's subtle, it can be insidious, it can happen on the turn of a dime. So we are medical professionals and clinicians are vigilant about what is usually called postpartum psychosis. If there is psychosis during a pregnancy, you're probably dealing with a patient who has a history of a psychotic illness. But when you see psychosis anew in the postpartum, and by psychosis, I mean loss of touch with reality, where you can have delusions, strange beliefs, hallucinations, seeing or hearing things that aren't real, feeling confused, feeling disconnected from reality. You have a decreased need for sleep often. Paranoia is common, suspiciousness. and there's a lot of difficulty communicating. If you're seeing this anew in the postpartum period, because this can happen within a week to a few weeks to a month, it tends to happen on the early side, you can flip into this psychotic state. You tend to be an undiagnosed, until proven otherwise, women who experience this brand new are probably bipolar and never knew it. And this event of pregnancy and postpartum and parturition, giving birth in particular, kicks off the event, kicks off this illness that then appears as a psychosis that is dangerous. Because if you can't make sense of reality, you could harm yourself and you can harm the baby. So these are emergencies. These are the women that need to be hospitalized and sadly separated from the babies, but safety first. These are emergency situations. Shifting gears.
Oh, there I was. Sorry, I was muted. So mentioned in the very beginning of this that there's a couple of screening instruments that are kind of standardly used with perinatal women, particularly to screen for depression. The EPDS, the Edinburgh Postnatal Depression Scale, really is the gold standard. It is 10 questions that a woman answers and can score anyone from 1 to 30. And typically we consider anything over a 10 to suggest that there might be a Pmad at play. And it's very easy to access. It's all over online, but this really is kind of one of the most empirically utilized and across the board screening instruments to determine. Another more common screening instrument that's starting to gain a lot more traction is the PHQ-9. This is the patient health questionnaire. It has 9 questions that I oftentimes see used, particularly in pediatric settings. And then there's also the PHQ-2, which is 2 simple questions that speak to little interest or pleasure in doing things, feeling down, depressed, or hopeless. If somebody answers yes to one or both of those questions, sometimes then the PHQ-9 is administered. So a lot of times you see those used together. There's a number of other instruments that we use at the Motherhood Center and that others are starting to use more and more as well. There's the GAD-7 that looks specifically at anxiety. There's also the PBQ, which we have started to use quite a bit at the Motherhood Center. That's all around the parent bonding questionnaire. So that really looks at the dyadic relationship between mother and baby. So these are some very standard screening instruments that are used. And if you haven't started using these at your practice, I strongly encourage you to. Just one thing I want to add about screening, which I think is really important, is that it is not a fail-safe standalone mechanism. There's research that suggests that screening as a single approach may not be adequate due to cultural mental health stigma and a variance of risk factors in racial ethnic groups. And I think this also goes across the board. I cannot tell you how many women we've treated at the Motherhood Center that have said, oh yeah, I got that screen one time, many times from my OBGYN or from my pediatrician. I was not honest. I didn't tell the truth. I didn't want anyone to know how bad it was. And so we see a lot of that, again, deeply rooted in that 80% of women who don't get the treatment they need and deserve because of the shame and stigma that surrounds new mothers who are feeling this way, this hopeless, and this depressed and anxious. And so we wanted to throw a slide in here to talk a little bit about how do we have this conversation with a new or expecting mom, right? That can be a hard conversation to have. And particularly when we talk about this concept of integrating other supplemental factors into administering a screen, these are things that can set the stage for a woman, hopefully, to be feeling comfortable to be honest on her screen. And also, you know, as in regards to screening, I know there's a lot of practices that do it differently, right? The administration of a screen, I understand, in a private practice or a hospital, it's a hard thing to get up and running and systematize. And so I realize that what I'm suggesting takes a lot of manpower to implement, but The more we can get away from just handing the screen out and asking a new or expecting mother to fill it out, and really have a conversation with her about the screen, explain to her what it is, explain what PMADs are, even go through the questions. The EPDS, as much as we love it, has been getting some pushback a little bit more so recently because some of the questions are a little outdated and a little confusing, particularly for people where English is not their first language. And so actually having a conversation as we go through this screen can oftentimes yield a more truthful outcome of how someone is actually feeling. So a couple of tips on how we can better integrate both screening and PMAD education into our practice with new and expecting mothers. I mean, education is key. It's prevention. The more that we can get ahead of PMADs, the more that we can normalize them, the more that we can make new and expecting mothers and their partners aware of what they are, so that if it happens to that particular new or expecting mother, it's not the first time she's heard of it. She knows what a Pmad is. She knows the signs and symptoms. She knows what to look for. She knows it's the #1 complication associated with childbirth. So if it happens to her, she's going to be a lot less likely to keep it to herself because she will have heard about it. And she knows she's not alone, so much so that this is something her OBGYN or pediatrician or lactation consultant or doula or whomever comes in contact with her is telling her about. So psychoeducation is critical. And I also always like to say, not just for new and expecting mom, when we have access to a couple, for those that are in a coupled relationship while expecting a child, it is so critical for partners to hear about this also. One of the reasons why our logo for the Motherhood Center is a life preserver is because so often when women are struggling from a PMAD, they feel like they're drowning. I cannot tell you how often water and the concept of water and drowning and tidal waves and paddling comes up again and again and again for women that are struggling with a PMAD. And again, it's why we have this life preserver. But for so many of them, while they are in that place where they are just paddling as fast as they can to just stay afloat and breathe, they're waiting for someone to throw them that life preserver and pull them out of the water because they cannot do it on their own. And that's where partners can come in. And so the more they know about PMADs, signs and symptoms, what to do, the better armed the couple is to deal with it, right? Because when you're a new or expecting mom who's struggling, you're not going to be able to diagnose yourself. Sometimes you're not going to have the ability to pick up the phone and start calling doctors and making appointments. So we have to involve partners in the educational component of this as well. As much as we can, we want to ask a new or expecting mom, how are you doing? Like, how are you really doing? How are you feeling? Again, we so often lose sight of this very simple question, especially when the baby comes, because we shift entirely over to the focus on the baby's health and well-being, which is critical, but so is moms. As we saw before, a well mom is a well baby. I kind of go against the grain. In my intro, you heard a lot about my own personal experiences, which is what brought me to do this work. So right out of the arena, I started sharing my story. But if appropriate, we can also use ourselves or just the concept of PMADs, right? PMADs are so common. I know so many people that have struggled in the perinatal period, that have experienced postpartum depression and anxiety, even people I know, it's that common, and it's totally treatable, right? This is so important, and Dr. Birndorf and I cannot say this enough. PMADs are treatable. We know how to help women feel better. It's actually quite easy, especially for those of us who specialize in this field. So there's hope, right? There's hope that if you get the treatment that you need, you are going to feel better. You can feel better. Normalizing PMADs as much as we can, letting women and their partners know they're incredibly common, bringing it up again and again, right? we never know what a new or expecting mom is taking in at what point. So, we don't want to just mention PMADs once. It's something we want to come back to again and again and say, remember we talked in the beginning on our first visit about perinatal mood and anxiety disorders. I just want a refresher. How are you doing? Have you noticed any emotional changes? Anything in the way that you've been feeling? Perhaps revisiting some of the symptoms and just saying, have you experienced any of this? There some of the screening initiatives that have manifested on a local, state, and federal level have made some recommendations around screening at the 6-week OBGYN visit. That's great. And what we're learning and what we know to be true is that Pmeds can manifest at any point in the perinatal period. So anywhere from the moment a woman gets pregnant until up to 1 year postpartum, those symptoms can manifest. So one screening is not enough. We need to start doing it more routinely. I will even suggest to those who have the ability to do so every 3 months. Like, I know that that's very, very, that's very frequent and might be difficult to do, but we cannot just rely on one, because a woman might be symptomatic 3 months after the baby's born, 6 months after the baby's born, right? Statistics show us and data shows us that there's a very high prevalence rate in the immediate postpartum, but there's also many, many women who experience it later on down the line, and it could be associated with a life shift, going back to work, stopping breastfeeding because of all of the hormonal shifts and changes. So we need to be asking and educating along the way. Assessing for mental health, right? What is your mental health history? Letting patients know, because you have a history of depression and or anxiety, you're at a greater risk. You should know that. So let's talk about it. What does it look like? Encouraging women, we talk so much, and rightly so, on creating a birth plan. We also need to encourage women to have a mental health plan, right? If you do feel this way, let's make sure that you have people to call. Is there a therapist in your neighborhood, or is there someone that you can reach out to virtually? Is there a reproductive psychiatrist who specializes in prescribing and managing medication during pregnancy and the postpartum, like Dr. Birndorf? Knowing who to call if you feel symptomatic, posting it on your refrigerator, whatever it takes, it's important to do that work ahead of time in the event that you need to call upon those resources to support you. And most importantly, it's one thing to educate, it's one thing to normalize. We need to hold ourselves accountable to have concrete resources and referrals available to women that are symptomatic. And even if they're not, right? Making sure that people know who they can call. PSI, again, is a tremendous resource. They have a listing of all of the maternal mental health providers across the world. And all you have to do is search in your area of location, and they will give you all of the clinicians that are maternal mental health specialists, right? So they're a wonderful resource. Certainly the Motherhood Center, if you are in the New York, New Jersey, or Connecticut area, the tri-state area. But making sure that you are giving somebody a concrete resource to call in the event that they are symptomatic. And then what can I actually say? I know that for some, it can feel like, how do I actually have the conversation? And just wanted to provide a couple of prompts to get you thinking. Something along the lines of, becoming a new parent is really hard. Everything we see around us makes it look blissful, wonderful, and easy, when it can actually feel really overwhelming and exhausting and anxiety provoking, sometimes even regretful. How's it been for you? I cannot tell you how many women feel a sense of regret that they had a baby, and how awful it feels to feel that way up against this backdrop of what we think it's supposed to be. When I drop that word regret, the sigh that I see come over a woman's face, that I gave her permission to have this feeling, it's like the biggest weight is lifted off of her shoulders. Oh my gosh, that's how I feel. I do regret this, right? And that it's okay to feel that way. So much of what we talk about at the Motherhood Center is this concept of both and I know I'm going off script a little bit, but I think it's really important, is that, we have this perception of what it's supposed to be like, what it should be like. And what we always encourage women is like, Motherhood is so filled with ambivalence, right? We can look at our baby and think, oh my gosh, my baby's so cute, and I feel like I made the biggest mistake of my life. Both can be true. Both can and will exist forever in motherhood for those of you who have had children before. I love my teenagers and they drive me crazy, right? It's the definition of having a child. And the sooner we can learn that and give ourselves permission to have those, the more of a relief again we can feel. One does not annihilate the other. Just because I feel like I might have made a mistake doesn't mean I don't still love my child. Other things we can say, I wanted to discuss something very important with you during our visit. 20% of all new and expecting moms experience something called a Pmad. I know so many women who've experienced postpartum depression and anxiety, and they didn't even know what was happening to them or how common it is or how to get help. We can have a brochure handy. Here's a brochure that describes Pmads in a little bit more detail, so that in the event that you ever experience any of these symptoms during pregnancy or after the baby comes, you know what it is and you know what to do. We actually created a pamphlet that we've been sharing with a lot of providers out there, which I'd be happy to share with Evelyn to pass off to everyone. And you can use that. It has all the language in there, and you can just hand that to your patients as a resource. And then finally, after the baby comes, there's so much attention on the baby and so little attention given to mom. A new mom's body goes through so many physical and emotional changes. It's hard to know what's normal and what isn't. How have you been feeling emotionally since the baby came? So just a couple of ways to start the conversation. And then Dr. Birndorf and I wanted to just spend a few minutes before we launch into questions, of which I see that there are many and we are very excited to answer. Just talking a little bit about what we do at the Motherhood Center, and also in this conversation to just also illustrate the different types of treatment modalities and offerings that are available that can be used as resources for women that are experiencing perinatal mood and anxiety disorders.
So our mission at the Motherhood Center is to effectively diagnose and treat women in New York City and surrounding areas suffering from perinatal mood and anxiety disorders. We always throw in postpartum depression because that's what most people have heard of. So that's what we do. We're a treatment center. We have three different kinds of, three different arms, if you will. We started, or because there was no such thing as a freestanding perinatal day hospital. So what a day hospital, a day program is, it's a partial hospital program. And I'm guessing many of you know what that means, but that is when you are in person, or for the past few years, virtual, and we're now going back to both in person and virtual, 5 days a week, 5 hours a day, 10 to 3. It's group therapy. They're all group-based therapies, mother-baby treatment, dyadic treatment, individual treatment, couples, medication management. It's all inclusive. It's a single bundled care treatment, and you get everything included in that. It's unique. It exists nowhere else in the country. There are a handful of programs like this that exist in hospitals or behavioral health programs nationwide, but we are the only one that exists like this. And we are trying to prove a model, a level of care is necessary and so important for women. It's like missing between inpatient and outpatient, right? There's this abyss. It's hard to go from being an inpatient, see you once a week, see you once a month. We also have outpatient treatment, individual therapy, medication management, couples work, dyadic work. And then we have a robust support and education arm with support groups, webinars like this, advocacy work, and Paige heads that up and does a tremendous job.
And I just wanted to add to this, when we think about treatment kind of on a more global scale, these are all different treatment modalities that women respond very well to, right? When we think about the spectrum of Pmad acuity, there is a spectrum, right? There are women that have mild symptoms, moderate symptoms, and acute symptoms. So when we look at kind of the spectrum of treatment, for women that are experiencing more mild symptoms, perhaps a support group is something that they would respond very, very well to. Being in a community of other new and expecting mothers that are struggling, talking about the hard parts of motherhood, having their own experiences normalized and validated can be a great experience for them and can cause some relief. But for other people that are struggling, they might benefit more from speaking with an individual therapist, a maternal mental health specialist, and seeing that professional once a week or even sometimes more. And sometimes with a supplement to that, meeting with a reproductive psychiatrist who specializes in meds that are safe and effective to take during pregnancy and the postpartum. And then, sometimes all three of these things can be very helpful. The next step of acuity, when we're looking at the more moderate to acute symptoms, then something like our day program or our partial hospitalization program would be a wonderful intervention, because that person needs something higher, a higher level of care than outpatient treatment, but isn't necessarily requiring an inpatient level of care, right? And then for patients that are actively psychotic, suicidal, or risk to themselves or others, that person, the acuity of those symptoms, they do need to be in an inpatient facility to receive treatment to minimize those symptoms and stabilize that patient. And even as we're here today, and I'm trying to organize a discharge from an inpatient facility in New York to our day program, we get a lot of step downs. So we treat a lot of women in the day program that were hospitalized for SI or for psychosis that come to us for treatment after. So this level of care, as Dr. Birndorf said, it's very special, and we don't see it in a lot of other places, especially or unless it is embedded in a hospital system of which we are not. Sorry to co-opt that from you, Catherine.
No problem. We could talk endlessly about this. I see all kinds of questions about how do you get in, so we're gonna come back to that. Right, so we've had for the last 2 years, a virtual program. We had to just pivot. We took our women that were in person. We have a nursery on site. We took the women and babies, all of us cleared out on March 13th. We shut down March 13th, 2020, and we practiced virtual over the weekend, and we opened up online on Monday morning, March 16th, 2020. So everybody was at home. Everybody will remember this period of time forever. So we moved in the national crisis to a telemental health platform, and we're gonna be opening, not in the fall, we have to change that page. We're opening actually April 25th to have but this has been a moving target. We tried to open before Delta, we tried to open before Omicron. We're hoping to be able to open before BA2, and hope BA2 is not what these other two have been. We run a high quality intensive treatment program for women who are pregnant or postpartum, experiencing acute symptoms of anxiety, depression, bipolar disorder, PTSD, OCD, or psychosis. You cannot be unsafe or needing hospitalization, but you can be just out of the hospital, and we want you in our program. You can also be the other end of the spectrum, which is you're kind of not really making it in the outpatient treatment world. You just need more support. You need work on attachment. We're a very attachment-based program. So we treat women on a wide spectrum of acuity, somewhere between they need more outpatient and they're just stepping down from inpatient. I hope that intermediate level of care makes sense. So that's what we're doing. We provide all different modalities of treatments, right? They're all evidence-based. They're led by psychologists, social workers, psychiatrists, and they're incredible. Each is its own therapeutic intervention, right? So we have 5 of those a day. We always say in 1 month at the Motherhood Center, the treatment tends to run for about 4 weeks to 6 weeks if we can get insurance coverage for that. It's 2 years worth of outpatient treatment. So it's better, faster. That's a page line. So I'm sorry, but interpersonal psychotherapy, cognitive behavioral therapy. We do DBT, we teach skills. We have a whole skills track. We do trauma-informed movement. We do DBT-informed art therapy. We have a dyadic mother-baby treatment. We have a partner support group that Paige runs. We have a nursery where we have somebody supporting baby care. And we have all kinds of other things that go along with this. So we really are trying to create a model that we could, there's only one center right now. I know somebody had asked that. Our goal is to prove this model and have it be everywhere. Take every insurance and treat women everywhere with great access. We're trying to prove that. We are doing a pretty good job, as we have, we know we have research, we're studying the women that have been through our program, and we do find both, just so you know, virtual care, as evidenced by this graphic that's up right now, it is equally efficacious to in-person care. So now it's like mind-blowing. Who would have ever thought we could diagnose psychosis over the screen, that we could treat bipolar illness over the screen? I mean, we are doing things we never dreamed of, but we had no choice. And when you have no choice, you make it work, because you are not going to let these women down, right? We're not going to stop. And what we've proven is that there's equal efficacy, as evidenced by the scores in the EPDS for both in-person treatment and virtual treatment. So we were super excited to learn this, and this paper is in for publication. We're trying to get that published so that people understand this can be done virtually with excellent efficacy.
We also offer an outpatient arm, as we mentioned a little bit in the beginning. So we do offer individual therapy, medication management. We also do trying to conceive consults. So for women who want to become pregnant, but are currently taking medication and are curious, should I stay on it? Should I not? Should I switch to something else? I just want to say, and this is really Dr. Birndorf's, her whole area of expertise is, one of the things that can be somewhat heartbreaking is because there isn't as much education and training is needed out there about what medications are safe and effective for women to take during pregnancy. And I understand to an extent, right? It can be scary from a liability purpose to counsel somebody without that area of expertise on whether or not someone should stay on their medication. We see so many women that were advised to stop taking their antidepressants or whatever meds they were on once they become pregnant. And what ends up happening a lot of the time is they become symptomatic again, right? And so we will see women come to us saying, I was on this, I was on that, I was advised to go off it, I'm feeling incredibly anxious, I'm feeling depressed again, what do I do? Or adversely, women who really white knuckle it throughout their pregnancy, right? That are in such emotional distress because they were advised not to. And I just want to offer to all of you that are not experts in the area of what meds are safe and effective during pregnancy and postpartum, there's a number of resources out there that are available to MDs in particular and prescribers to find out and speak to an expert about what is safe and what isn't. Postpartum Support International, again, I know we're giving them all kinds of accolades. I hope someone from PSI is in the audience today. They recently started a hotline for providers to schedule a time to speak with a reproductive psychiatrist to present the case and find out if in fact this medication is safe for someone to continue to take during pregnancy. Also here in New York State, there is a program called Project Teach that has also a hotline that MDs and others that prescribe can call and schedule a time to speak with a reproductive psychiatrist. And correct this if it's not wrong, if it's wrong, Catherine, but Mass General also has a similar, no, Mass General actually, their MDs are the ones that man or woman the Project Teach line.
I would also add, yes, that's correct. Postpartum Support International also has a national consult line that began a couple of years ago. And that is a line that's like a curbside consultation. So let's say it's mostly doctor to doctor. I was part of helping to start that. And we started with sort of like, if you're a doctor in the middle of North Dakota and don't know what to do for your patient, you can call to speak to an expert about the specific perinatal issue. So we recognize there are not a lot of, New York City is robust with resources, but most places aren't. So we get that. So we're trying to figure out ways to be available consultatively to help. And there are a lot of organizations that are doing a bang up job making this happen.
And then just lastly, some of the things that we offer in the event that you found this helpful, or if you would like to just access a library of resources that we have that are available for free on our website. We've done a litany of webinars, particularly in the past 2 years during the pandemic, that have to do with all kinds of facets of perinatal mood and anxiety disorders. In particular, for women of color, what's the role of a doula. We just did a webinar with a midwife and how midwifery can have an impact on minimizing Pmad rates and lowering C-section rates. There's probably about 40 available now on our website. So if you're interested in accessing any of those, again, they're free. And then we do support groups. We do a Pmad support group, a pregnancy support group, miscarriage and loss group, and one that has become very popular, which is our Having a Baby After a Pmad support group. For women that have had a Pmad the first time around or the second time around, there's so much fear, understandably. Do I have another child? If I have another child, how can I take some control over my experience the second or third time around to minimize the possibility of having a Pmad again? And then, PSI also has a number of support groups too, but these are the ones, and our support groups are actually open to women across the world. We don't have to because they're support groups, they're not clinical groups. I've had people join from Taiwan, Japan, Australia. So certainly use those as a resource as well. And that concludes our presentation. I know we ended a few minutes early. I hope that's okay, Evelyn, because I know there's a ton of questions and I want to leave a lot of time for those.
Absolutely. Thank you so much. This was so interesting and really just so much information. People are really curious. There's a lot of questions about the Motherhood Center. So I see you have the link here, and is the link on this? Yeah, I think it would be important if you could just chat in where people can send questions in terms of the Motherhood Center. And there's a lot of questions. The pamphlet you mentioned, people are really eager to get, so you and I can connect after and maybe get some of these resources together for people. So there's a lot of questions. Let me start. One of them is I've heard psychiatrists talk about Pmeds and differentiate it from other mood and anxiety disorders, mainly due to hormonal changes. Can you address that?
Yeah. You would think it was like an obvious answer. Sure, we know hormones are different at this time of life. We cannot prove that that's what's causing this. So we can't, but by that token, we can't treat with repleting hormones, right? It sort of doesn't line up like that. So I always say hormones are certainly part of the background. The hormonal fluctuation, if you're someone who's struggled at different times of life where there are hormonal changes, PMS, peri-period, and you're probably going to be a perimenopause, it's probably going to be hard then too. You might be a perinatal, might struggle during the perinatal period. So certainly we know there's something up. We cannot blame this on hormones. We cannot say it is caused by hormones. They're in the background. And I think if you're someone who's particularly sensitive to hormonal fluctuations, and generally what we know by the time someone has a baby is that was true of their PMS, PMDD kinds of things, they might be more likely, but we cannot hang our hats on it. We cannot use hormonal treatments to make things better. That's not what's worked. So, again, Paige and I say things that I don't know that I'd write down, but like if someone needs to say it's caused by hormones, go ahead, say it. Because sometimes people just need to not have it be, they're like, oh, it's just in my head. My partner will never understand. My parents culturally, this is not okay. If I say it's hormones, it's better. Say it's hormones. Hormones are involved, but they're not necessarily causal. And to that end, we don't exactly know what causes perinatal mood and anxiety disorders. This is Untitled. So I hope that answers that hormonal question. It is certainly a time of hormonal flux. It contributes, but it is not necessarily causal.
Thank you. So another question is, can you comment on the differences related to different ethnic and racial groups that you referred to?
What I would say is that certain, culturally speaking, different groups are more or less comfortable with mental illness. And so I think what happens is often these Pmeds don't discriminate. Everyone is equally, I don't want to say able, but may experience these disorders. Everyone may experience them similarly, but they won't know what the symptoms are because of their culture, or the culture doesn't accept that there are problems psychologically. No one's talking about it. People are not encouraged to come for help. In fact, they're stopped from going for help. So it really more has to do with kind of the acceptance. I would say it's more about mental illness and the treatment of it, talking about it, diagnosing it, being able to treat it is very culturally based. So we do see higher incidences in certain cultures because we may or may not be able to get to it. But that said, I would say it's an equal opportunity. It's a non-discriminating. These are medical illnesses that happen to everyone. Nobody's safe.
I just also want to say that we will put the evaluation in the chat box. So I want to remind people to please fill that out, as Meg had mentioned before. Another question is, given the impairment in mother-infant interactions as a result of Pmads, how would you evaluate whether mothers should be treated individually versus in dyadic treatment as the timing of Pmads is relational to their baby?
It's a great question. I would say, we always start with the mom. And we almost always, when a baby is young, bring the baby in. So we train all our clinicians in dyadic work. That's very unusual, by the way, super unusual. So we want all our clinicians to be able to speak to the dyad, but it's really hard to find out. Columbia, I saw somebody putting in, there are certain programs around that have dyadic specific treatment, but I would say that's not the norm. So usually you start with the mom, you bring the baby in, you try and understand the relationship, and that's part of the individual treatment. That's more typical. I hope that answers the question. Great. One other question that kept coming up that I really wanted, before people jump, everybody asked about timing. So yes. I have a 20 and 23-year-old, and I just want to say, I always say, once postpartum, always postpartum. So if it's like I say it as a joke, but I also say it as like, there's no end, right? We've just had to come up with a time frame from the minute you're pregnant to 1 year postpartum. That's arbitrary. You could have a 5-year-old kid and have your depression or anxiety started before you were pregnant and never got treated and was exacerbated in pregnancy and even further postpartum. That's what makes it confusing. And people will say, well, is this or isn't this? Don't get caught in that. If someone's got a symptom or a problem, treat the damn thing. It doesn't matter. Don't get caught with the words. The words get people very confused. It's depression, it's anxiety, it's happening at a time. People say, well, it's not postpartum anymore. Well, okay, so it's not. Treat it. What's the difference? Treat the thing.
That's great. And I mean, one of the questions was really, where's the threshold and how do you determine what is kind of normal? And I think that that's a great response to that. Somebody said that in their program, their current use the EPDS and the PHQ-9 at intake, and wanted to know whether that was, is it negative to be or repetitive to be using both screenings? Or is there a benefit to using both?
It may be repetitive. The EPDS is specific, validated in both pregnancy and postpartum. We could look, is that up to a year? I don't know. It's more, it's validated for use then because they are trying to distinguish some of the normal responses to pregnancy and postpartum. Somebody answered that too, or asked that question. People get confused because they're like, wait, of course I'm sleep deprived. My appetite's off, my concentration's terrible. The things that are, I meant to say this, the things that are never normal, hopelessness, guilt, shame, loss of joy, those are never normal. Sleep, appetite, right? Energy, concentration, those things all change in pregnancy and postpartum. Sorry, I answered a different question while I was answering another question. Now I forgot the original question. What was the original? I can't remember.
I think you answered it. That's great.
Okay.
Somebody else had wanted to know, what are your thoughts about using the antenatal risk questionnaire in OB clinics?
Oh, I remembered the other. PHQ-9 we use in women who are trying to conceive, people who are done being pregnant, kids. It gets used, it's a much more general screener. EPDS is more specific to pregnancy and postpartum. I am not familiar with the antenatal screener that might be used in an OB office, so I can't comment on that.
Great. And I think this question is for Paige. Is there any advocacy work being done on the cultural level regarding education about the actual range of experiences for pregnant and new mothers, PSAs or whatever?
So, you know, again, hats off to PSI. You know, they have organized all kinds of events across the world. One of which is a Climb Out of the Darkness event. So there are ways in which PSI can work with a local chapter to organize and orchestrate raising awareness events in that particular community. What I will say, and I want to put on everybody's radar, is May is Maternal Mental Health Awareness Month, and May 4th is International Maternal Mental Health Awareness Day. And so after we're done here, Dr. Birndorf and I are going to put our heads together and see how we can try to reach out to press and others and try to get some more stories out there in the month of May, which also coincides with Mother's Day. So there are a number of groups that get together in the month of May and organize different types of awareness and education campaigns. You know, there's a few states that have done some really successful campaigns, like New Jersey, Speak Up When I'm Down. But I'd be happy, Evelyn, to send some resources your way to share with the group about specific actions and ways that people can make a difference. MMHLA, the Maternal Mental Health, I want to say Legislative Alliance, is a group that spun out of PSI that works specifically on public policy and legislation as it pertains to maternal mental health. They're another great resource. You can join their newsletter. They'll send you all kinds of updates on direct actions that are targeting the federal government to raise more funding for screening, education, and treatment. But I'll make sure that you have something to share with everybody, Evelyn.
That sounds great. There were several questions also about kind of the hesitancy of mothers to leave their babies to actual comfort treatment, maybe the partner's kind of resistance around a mother seeking help. And also a question about, you know, have you ever had situations where because a mother was in treatment, the father sought custody? So I guess the question is, you know, what are some of the resistances you find around people coming forward to get treatment and some of the potential feared consequences?
They are endless. They are endless. And we are always up against this. And everything we do, we are keeping in mind the potential for this to be used against someone, right? There are a lot of complicated situations that we see, and we are advocating for the mom and her wellness. And we try very hard to stay out of you know, the legal and the legalities that do exist. We can't do it as much anymore. Medical charts. We're very careful. I mean, we're as careful as we can be, but people are scared. They don't say things. They don't want to come forward. They say, if I tell you an answer to this, my partner's going to use it against me. We are advocates. So our job is to help people get better, do our best to protect them and advocate for them. Does it always work? No. Do we have to call ACS when as mandated reporters? Yes. Do we work very hard on prevention and anything we can do to support someone so that situation is not the case? Yes. It is always complicated when there is an adversarial situation. And we've had plenty of spouses. We keep our door locked. We are very careful. We've had a lot of, restraining orders. We are very cautious and don't identify anyone. If someone calls to say, like a hospital, is somebody there, we can either confirm nor deny. We are real careful. But it's always a risk, and therefore people don't come forward, and they are scared of violence, and they should be. and we are there to help and treat as much as we possibly can.
Terrific. And, there are a lot of questions about resources, about where you can send mothers, what kind of insurance is taken. Nicole chatted in our own network and some of the work that we're doing around working in the perinatal period. So I think what we will do is try and compile some resources following the webinar to send out to people, including the pamphlet that Paige mentioned and the link to your website as well. And just to say that there's been a tremendous response in the chat box. I think this has really triggered a lot of enthusiasm and excitement about the work needing to be done, and really appreciate bringing this to our attention here. So thank you. And I just want to give people a few minutes to please fill out the evaluation that's in the chat box. And we thank you all for participating. Thank you, Paige. Thank you, Dr. Birndorf. This has been so rich and so informative.
Well, thank you so much for having us. I'll get you everything that we promised. And please want to encourage anybody who has any questions, both Dr. Birndorf and my email is there. Feel free to reach out directly.
We have one phone number, just so you know, there's one number, that's what you can call. And just to be clear, because the insurance question got asked, we work with all insurances in the day program. We do not accept Medicaid. That is sad and yet true. So we do have some opportunities for charity care. At this point, we cannot do it yet. And we do work with all other insurances, including the worst paying ones. So we'll take anything. We will work with everything. Okay. So that's
terrific.
Just to know.
And just to say that our early childhood treatment network, which is clinics located in the 7 boroughs, is really embarking on doing a lot of perinatal work. We will also send you the flyer to let you know about referrals to that program. And we're also piloting some models in OB/GYN, really in terms of co-locating professionals. So this has been really exciting, and I hope the beginning of a lot of really incredible work. So thanks so much, everybody. Please don't forget to fill out the evaluation. Thank you for joining us.
Thank you.
Thanks.